Hi everyone, today I'll be talking about Endocrine Society Clinical Practice Guidelines for the management of hyperglycemia in hospitalized adult patients. Recommendation 1. In adults with insulin-treated diabetes who are hospitalized for non-critical illness and are at high risk of hypoglycemia, the use of real-time continuous glucose monitoring with confirmatory bedside point-of-care blood glucose testing is recommended. Patients identified as high risk for hypoglycemia include age greater than 65 years of total daily dose of insulin greater than 0.6 units per kg, stage 3 chronic kidney disease, chronic liver failure, history of congestive heart failure and cerebrovascular disease. This recommendation does not apply to situations in which continuous glucose monitoring is not accurate, such as patients with extensive skin infections, hypoperfusion requiring vasopressor therapy. Recommendation 2. In adult patients using insulin pump therapy for diabetes prior to the admission, suggestion is to continue these patients on insulin pump rather than changing them to subcutaneous basal bolus insulin in the hospital. However, patients with impaired level of consciousness who are unable to appropriately adjust the pump settings, patients admitted to intensive care unit, and patients with diabetic ketoacidosis or hyperosmolar hyperglycemic state are not candidates for inpatient use of insulin pump. Hospitals need to have policies and procedures, including patients' informed consent and standardized order sets in place, as well as expertise from healthcare professionals to continue insulin pump therapy. Methodology for converting continuous subcutaneous insulin infusion to scheduled basal bolus insulin. If the basal rate settings on the insulin pump are known, then one would continue the same amount of basal insulin in the form of insulin glargine once a day. If the patient is taking prandial insulin at home, one would continue the same dose of prandial insulin in the hospital. For patients not using prandial insulin via the insulin pump at home, then one would use weight-based fixed premeal insulin dose at 0.2 to 0.4 units per kg per day divided in 3 doses. For patients who are not eating, then one would hold the prandial insulin. If the basal rate setting on the insulin pump is not known, then one would calculate the basal insulin dose of 0.2 to 0.4 units per kg per day and administer it as insulin glargine once a day. One would also use weight-based fixed premeal insulin dose at 0.2 to 0.4 units per kg divided in 3 doses and hold the prandial insulin if the patient is not eating. Recommendation 3. In adult patients who are hospitalized for non-critical illness and experience hyperglycemia while receiving glucocorticoids, suggestion is to start them on basal bolus insulin regimen or NPH insulin. Hyperglycemia occurs in 50 to 75% of hospitalized patients receiving supraphysiological dose of glucocorticoids, either with prednisone or methylprednisolone or hydrocortisone. Recommendation 4. In adult patients hospitalized for non-critical illness who are receiving enteral nutrition while in the hospital, suggestion to start them on basal bolus insulin regimen or NPH insulin. Recommendation 5. In adult patients with diabetes who are hospitalized for non-critical illness, suggestion is to provide inpatient diabetic education as a part of comprehensive diabetes discharge planning process. The diabetic education can be provided by certified diabetic care education specialist. Recommendation 6. In most adult patients with hyperglycemia with or without history of type 2 diabetes hospitalized for non-critical illness, suggestion is to start them on scheduled insulin therapy with basal bolus insulin regimen instead of non-insulin therapies. Non-insulin therapies include oral medications such as metformin, sulfonylureas, thiazolidinediones, glucagon-like peptide agonist, sodium glucose cotransporter 2 inhibitors, and DPP-4 inhibitors. DPP-4 inhibitors may be appropriate in select patients with type 2 diabetes, including those with established non-insulin requiring diabetes nearing hospital discharge. Select patients include those with type 2 diabetes that are moderately well managed with hemoglobin A1C less than 7.5, blood glucose less than 180 milligrams per deciliter. Recommendation 7. For adult patients with diabetes undergoing elective surgical procedures, target preoperative hemoglobin A1C level to be less than 8% and blood glucose between 100 to 180 milligrams per deciliter. These recommendations apply only to patients who are scheduled for elective surgical procedures, who have a reasonable amount of time for implementation of therapy to improve their hemoglobin A1C or blood glucose level. Blood glucose concentration should be within the targeted range of 100 to 180 milligrams per deciliter 1 to 4 hours prior to surgery. Recommendation 8. In adult patients with non-insulin treated type 2 diabetes hospitalized for non-critical illness who require prandial insulin therapy, suggestion is to not use carbohydrate counting for calculating prandial insulin doses. In adult patients with type 1 diabetes or insulin-dependent type 2 diabetes who are hospitalized for non-critical illness, suggestion to use carbohydrate counting or no carbohydrate counting with fixed prandial insulin dose. Diabetes. Recommendation 9. In adults with no prior history of diabetes who are hospitalized for non-critical illness and demonstrate hyperglycemia with blood glucose greater than 140 milligrams per deciliter, suggestion is to initially start with correctional insulin over scheduled insulin therapy to maintain blood glucose target in the range of 100 to 180 milligrams per deciliter. If patients do have persistent hyperglycemia with blood glucose greater than 180 milligrams per deciliter on 2 occasions in a 24-hour period, then suggestion is to add scheduled insulin therapy. In adults with diabetes treated with diet or non-insulin medications prior to the admission, suggestion is to start either on correctional insulin or scheduled insulin therapy to maintain blood glucose target in the range of 100 to 180 milligrams per deciliter. If the patient was started only on correctional insulin and if they demonstrate hyperglycemia with blood glucose greater than 180 milligrams per deciliter in 2 occasions in a 24-hour period, then suggestion is to add scheduled insulin therapy. In adults with insulin-treated diabetes prior to admission, recommendation is to continue them on scheduled insulin regimen and also continue on correctional insulin. Thank you.